very special session looking at a new thrombotic syndrome, spontaneous VITT. We have got most of the expert hematology panel here with us today. Sadly, Mike Macris couldn't make it, and we are going to have a session where Dr. Will Lester starts off with a case, Dr. Sue Pavord talks about recognition and diagnosis, and Professor Marie Scully will talk about treatment. So I'd like to introduce Dr. Will Lester. Unfortunately, he can't stay with us. He's got a big clinic, but he's going to talk about a recent case that he had that exemplifies the problem that we may be missing. Will, I think, is very well known, not only a member of the expert hematology panel, but he's a member of the Hemostasis and Thrombosis Task Force for the British Society for Hematology Guidelines Committee, and he's a consultant in Birmingham. Will, over to you.
Great, thank you, Beverley. I think it's always useful to start with a case. It just sort of, I think it's going to help with further discussions. And the family of this patient were very keen that we shared this for learning across the whole sort of thrombosis community. So this is a 37-year-old woman who had no past medical history of note, was 11 months postpartum, and presented to the emergency department with 5 days of just feeling generally grotty, but with 1 day history of abdominal pain. And investigations on admission showed a thrombocytopenia with an otherwise normal full blood count. When we looked at the blood film, it wasn't particularly remarkable, and there were certainly no red cell fragments. The clotting studies were abnormal, with a raised D dimer that was over 8,000 and a low fibrinogen. And biochemistry showed a mild transaminitis and a mildly raised CRP. So in summary, we've got someone with a short history with low platelets and features of DIC, and they're not obviously septic. So what next? What we tend to do when we're really not sure what's going on is just do a CT body, which is essentially what we did. And CT imaging of the abdomen and pelvis showed pancreatic inflammation, and they couldn't really visualize the portal vein very well. And there was a 16-centimeter splenomegaly. So we went on to do an ultrasound scan, which confirmed a portal vein thrombosis, but also some possible gallstones. Also there was some description of the liver maybe being a little bit coarse, although it wasn't particularly notable. So the working diagnosis at this stage was pancreatitis that had triggered a local portal vein thrombosis. Although the amylase was normal, possible maybe a bit of liver disease that was not previously known about, although it was very speculative. Initially given a dose of enoxaparin 40 milligrams because there was concern about that low fibrinogen and the low platelet count and bleeding, but there was no bleeding complication at all. So the following day, it was escalated to a full therapeutic dose. In terms of hemostatic tests, the working hypothesis was that this was a local issue, but we wanted to make sure there was nothing obvious in terms of hemostatic defect, certainly no features of TTP. An antiphospholipid screen was sent, which we tend to do, especially if we're thinking about catastrophic antiphospholipid syndrome. A PNH screen was sent, although obviously that's a very rare diagnosis. And for anyone with a splanchnic vein thrombosis, it tends to be almost automatic to do a JAK2 mutation screen. But unfortunately, 3 days after presentation, she suddenly became transiently unresponsive and then shocked with a lactic acidosis, so was transferred to ITU and was needing vasopressor support to maintain a blood pressure, but was otherwise alert and communicating, not needing any respiratory support. Went on to have repeat CTs, and a CT head actually showed a right middle cerebral artery territory infarct without any gross sort of neurology on examination. It was a bit of a surprise. And the CT abdomen showed hepatic and splenic infarctions with very extensive thrombosis of the entire portal system, including small bowel venous thrombosis and clear gross ischemia. So an emergency small bowel resection was performed. There was no blood product support, but actually no perioperative bleeding despite the low platelets and the low fibrinogen, and it was only 12 hours after a therapeutic dose of anticoagulation. Post-op put on IV heparin and appeared to stabilize. And we discussed her case. We didn't have any of the results back, like the APS results back at that stage, but thought this felt like some sort of immunological problem. So almost a blind dose of methylprednisolone was given. But the following morning, another test result came back, and this was the HIT ELISA test, and it was strongly positive. The normal test we use for HIT, the AccuStar test, was negative, but this was the manual HIT ELISA, and this is what we saw in VITT as well. And we started to set up for plasma exchange, but unfortunately she suffered a cardiac arrest, and unfortunately resuscitation was unsuccessful, and it was felt that it could have been a large pulmonary embolism, although it's possible that it was also a coronary event as well. In terms of further work on what was going on, in terms of tests, some tests were done on the NHS, and also then tests were done at the University of Birmingham. So what we identified, and this was not known until after the sad outcome, was that she'd had an acute CMV infection and was in the acute phase of that with very high IgM antibodies. All the other hemostatic tests, that not surprisingly, came back as negative. And in terms of her serum, when it was added to donor platelets with the source of PF4, then it caused platelet aggregation. That's what you're seeing here. But if you gave heparin, it would inhibit this. And this is because the antibodies that are binding here are binding to the heparin binding site. So heparin works almost as an inhibitor, and also a blocker for platelet activation as well will stop platelet activation. So essentially demonstrating that in her serum she had antibodies that cause platelet activation, exactly what we saw in VITT. So I guess, is it a call to arms? I think this VITT-like syndrome, and I think we all, we all agree on this, is that it's always existed, but we've missed it. I can certainly think back to cases of widespread thrombosis where we never got to the bottom of what was causing it, but with features of low platelets and high D-dimers. So I think we are missing cases, and I suppose the question is, should the expert panel that was set up for VITT, should we be using those recommendations again, instead of linking it with vaccine, however, linking it with patients who present, especially with unusual site thrombosis, like brain and liver, with high D-dimers at over 4,000 and thrombocytopenia. And it's just important for people to remember that the normal HIT screen, the automated HIT screens tend to miss this, so it has to be the manual ELISA. And just to finish, I just want to thank the patient's family. They've been very gracious, and they are very keen that this is shared, because they think if something good will come out of this, it will be raising awareness, and that we can diagnose people at an earlier stage, and therefore give the appropriate treatment that I know Marie's going to talk about later. I'd like to thank the guys at the University of Birmingham who have done some of the work on platelet activation, and also the medical team. This had a profound impact on the team. Then the nurses really struggled actually with what happened, and we had some junior doctors who helped, and some of the consultants on ITU, and our virologist as well. So with that, I will hand over.
Thank you, Will. Is there anything else you want to add before you leave to go visit your patients?
Not really. I mean, I'll be obviously really interested to hear what comes of the conversation later, so I'll have to catch up.
We'll have to catch up, and hopefully you might be able to come back in later, but if not, have a good clinic. Okay, so thank you so much for setting the scene around this new spontaneous VITT syndrome. I'd like to ask Dr. Sue Pavord to take over at this point to talk about where we're at. As you all know, Sue is now president of the British Society for Haematology, and she was our chair all the way through VITT, chairing the expert haematology panel. She's got lots of interests, but thrombosis and hemostasis is her number one. Over to you, Sue. Thanks.
Thanks very much, Beverley, and thank you, Will. A very sad case indeed, and that's why we're here really to raise awareness of VITT occurring without proximate vaccine. So just to recap very briefly, about classical VITT, because this was 3 years ago now. It seems a long time ago. So you'll remember the AstraZeneca, the Oxford AstraZeneca vaccine was an adenovirus vectored vaccine that was introduced to the public in January. On the first injection was January the 4th, 2021, to fight this pandemic, which eventually took over 200,000 lives of UK citizens. So the vaccine was rolled out in descending age, starting with the elderly. And after about 6 weeks, in middle of March, we noticed cases of young individuals, previously fit and well, who were coming in with widespread thrombosis, and in particular, cerebral vein thrombosis. So you can see here a cerebral vein thrombosis, splanchnic vein thrombosis and hepatic vein thrombosis, and huge increase in intracranial pressure with brain herniation at craniotomy sites. So there was a clear delay from the time of the vaccine and presentation with symptoms of at least 5 days, giving a clue that this was an immune-related disease. There were 3 groups at UCL, Marie Scully's group, in Norway and in Germany, that identified the platelet factor 4 antibodies. And we established daily meetings very promptly to learn from these cases and to help guide management and develop management guidelines as we went. Through collecting all these cases, there were over 450 patients presented to us. It was clear that there was a pentad of clinical and laboratory features that indicated a case of VITT. So these were occurring 5 to 30 days after vaccine. And sometimes if it was isolated DVT and PE, because that manifests a little bit later, then the days went up to 42 days post-vaccine. There was thrombocytopenia, so any platelet count under 150, but the fall in platelet count was also important. The presence of thrombosis and extraordinarily high D-dimers, showing such a massive pro-coagulant state. So D-dimers well over 4,000. And then the presence of these anti-platelet factor 4 antibodies. And we were able to define the likelihood of it being a case of VITT with the number of these features present. So if it was all 5 criteria, it was a definite VITT, 4, it was a probable, 3, it was a possible, and 2, it was unlikely. And these were the sites of thrombosis. So CVT was present in 50% of patients, DVT and PE were common, odd site thrombosis like adrenal, splanchnic vein, hepatic veins, and then about 1/3 of them had arterial thrombosis, and that was at presentation. So 29% of our cases had involvement of 2 or more vascular beds. But in fact, where screening was done in sites that were not symptomatic, it did show that multiple site thrombosis was present in 83% of patients. So let's look at the difference first between HIT and VITT in terms of the clinical features. The incidence of HIT is around 1% of patients on heparin, mainly unfractionated heparin, but rarely on low molecular weight heparin. And VITT occurred in 1 in 50,000 individuals after adenoviral vaccine. The incidence was less in the over 50s, but increased as in descending age, and probably about 1 in 10,000 in the under 30s. The presentation for HIT is considered a drop in platelet count of more than 30%, 5 to 10 days after the start of heparin. and thrombosis occurs in about 50%. And that's because largely these patients are hospitalized and the diagnosis is made at the point of thrombocytopenia because these patients are under monitoring anyway. Whereas with VITT, it's affecting previously fit and well individuals in the community who don't think to present. We're not monitoring their platelet counts, and they will present when the symptoms of thrombosis have developed. So 97% of patients with VITT had thrombosis at presentation. The sites of thrombosis are slightly different. For HIT, it's very much dependent on the pathological situation of the patient. So, for instance, if it's post-op, it tends to be DVT and PE. If it's related to cardiac bypass, then it tends to be myocardial infarction or arterial thrombosis. Whereas with VITT, there was a high predominance of cerebral vein thrombosis, which actually only occurs in about 2% of patients with HIT. In terms of our diagnosis, the clinical diagnosis, HIT relies on the 4Ts probability score to guide whether you would then go on and test. And VITT, we were using our case definition criteria, which was the pentad of features I've just described. So the platelet activation by the VITT sera showed platelet activation, if you look at this top right-hand box. If heparin was added, then the activation was diminished, and then it was inhibited by a swamp of excess heparin, just like HIT would be. But with HIT, we would see a rise in activation here when heparin is added to the assay. And this Canadian group identified that the VITT antibodies are in the same sites as the heparin binding sites. So there is competition for those sites on the platelet factor 4 molecule. So the platelet factor 4 molecule has this equatorial band of positive charge. And heparin binding sites, heparin has a negative charge, and it binds to these along that positive equatorial band. HIT antibody binding sites are more in the polar regions of the platelet factor 4 molecule, whereas the VITT antibody binding sites, again, in that equatorial positive band with some external sites. So the antigenic sites of VITT and HIT antibodies are very different, and that's important when we come to consider treatments. So how did we detect VITT antibodies? Well, the rapid assays were negative and the automated antibodies were negative in general. In general, they were negative. And that's because these antibodies are not dependent on heparin. And the binding is inhibited to some extent by heparin. So with these quantitative assays, the AccuStar, the rapid ones, the chemiluminescence assays, and the automated assays, they are using platelet factor 4 heparin binding to the antigen. So they're going to be typically negative with VITT antibodies. The ELISA assay is quite non-specific, and it's positive for both HIT antibodies and VITT antibodies. So that's the test that we were using in the UK to diagnose VITT in line with those other 4 clinical features. So this table is from Ted Walkington in 2008, and it was looking at HIT optical densities. And we would confer this with VITT as well. So the low optical densities are very non-specific. They did not equate to platelet activating antibodies. So found by ELISA, but at low titer, and were not platelet activating. And it was only when we got to levels of 1.4 optical densities and above that we had much more specificity. And this is what we saw with our cases presented at our daily meetings, that the cases that were genuine cases of VITT had very high optical densities from ELISA. And here are the platelet activation assays from Andreas Greinacher. This is the VITT sera activating platelets. It's inhibited by the addition of low titer heparin, and it's enhanced by the addition of platelet factor 4, and then completely neutralized by swamping with high-dose heparin. So let's look at the pathophysiology of VITT compared with HIT. So the VITT is the adenovirus vector vaccine. It it stimulates platelet factor 4 production, and antibodies are stimulated to platelet factor 4. So these are direct anti-platelet factor 4 antibodies, and they are monoclonal and oligoclonal, as opposed to HIT, which are formed to the platelet factor 4 complex, and they are polyclonal antibodies. So this VITT is much more of an autoimmune process than HIT. But both these antibodies, once assembled, they will activate platelets and leukocytes through their Fc gamma receptors. And that activation will result in thrombosis and platelet consumption. And in VITT, you have a high preponderance of cerebral vein thrombosis. And in HIT, it's usually venous thromboembolism, but where there is arterial disease, there's arterial thrombosis. And then the antibodies in VITT will persist for months to years, whereas in HIT, they tend to disappear by 100 days. When we look at the persistence of the VITT antibodies, this study from Linda Schönborn from Andreas Greineker's group has traced the VITT antibodies and finds that they do persist for weeks or months after the acute event, but actually the platelet activating ability of them has gone in 90% of cases by 12 weeks. So we would advise for countries that only use these adenoviral vector vaccines during the pandemic, we would advise them to have the second dose, providing it is after 12 weeks, if there is no alternative vaccine available. So what is it about the adenovirus vector? And this leads on to other causes without proximate vaccine. What is it about this trigger that we develop VITT antibodies, or we see VITT antibodies? And it appears to be a very strong negative charge from the adenovirus that binds on this strong positive charge from the platelet factor 4 molecule. And then that triggers, as I said, anti-platelet factor 4 antibodies, activates platelets and neutrophils through the Fc gamma receptors, and the activation of neutrophils produces netosis, so release of nets, which creates a scaffold for thrombosis, but also released from neutrophils is this DNA, which has more negative charge. And so this cycle of events sets up, which is self-perpetuating. And equally from the activation of platelets, more leukocytes are drawn in to the active site, and it's self-perpetuating platelet activation, thrombocytopenia. So this positive feedback loop develops, and that's why we see such aggressive thrombosis in this condition. The adenovirus vector vaccine is also not a pure vaccine. There are some hexans, some bits of the viral capsid still around in that vaccine, and other constituents, proteins and chemicals. And that all leads to this systemic inflammatory state, which again further perpetuates this cycle. And additionally, the AstraZeneca vaccine has EDTA, which chelates calcium, and calcium is necessary for the integrity of the endothelium. So there is capillary leakage on top of all this process going on. Hence, it's so rapidly progressive. And in terms of treatment, Marie will tell you, every minute is just so important in saving these lives. Now, there are other stimulants to causing VITT. So one is the Johnson & Johnson Janssen vaccine, and we analysed their data that were reported retrospectively. There were 86 of them. The incidence seems to be about a third that of the Chadox AstraZeneca vaccine, but nevertheless, during the analysis, we could see that the clinical features were very, very similar. It's the same condition. And this paper, a case report, showed VITT occurring after HPV vaccine. So this was a 25-year-old lady who had had a 9-valent HPV vaccine, having previously had 3 bivalent HPV vaccines. And she presented at day 10 with thrombocytopenia and a very elevated D-dimer, with right iliac vein thrombosis and bilateral pulmonary emboli. And she was treated with intravenous immunoglobulin with a fall in her D-dimers and a rise in her platelets, and treated with anticoagulation. So clearly a case of VITT there. Anti-platelet factor 4 antibodies were confirmed. And Ted Walkington last year has described 2 cases where VITT has occurred after adenovirus infection, again without proximate vaccine. So this was a young boy, aged 4 years old, who had onset of viral symptoms, subsequently shown to be an adenovirus. All other viral serology was negative. 2 days later, he presented with fever and abdominal pain and was admitted to hospital. 2 days after that, he developed bruising. A platelet count was done and it was 10. He then developed a CVST, and he was treated with prednisolone and anticoagulation, intravenous immunoglobulin with a transient rise in his platelet count, and then alternative anticoagulation with bivalirudin, but unfortunately he died of VITT. The second case was a 38-year-old lady who developed onset of viral symptoms, again subsequently shown to be adenovirus by PCR with no other viral serology positive. She had a rapid decline in her platelet count down to 36 at the same time as multiple strokes with complete left hemiparesis, right-sided visual loss, and ST elevation myocardial infarction. She was given intravenous immunoglobulin, steroids, and anticoagulation, and she made a reasonable recovery. So these are 2 cases following adenovirus infection. Will's case had acute CMV infection. Looking at this study from Andreas Greineker's team again, he used these 2 assays, a rapid anti-platelet factor 4 heparin assay for HIT diagnosis, and a modified rapid anti-platelet factor 4 assay, so heparin independent antibodies for VITT diagnosis, and negative controls. And through those tests, he tested the sera of 9 patients who had presented prior to the pandemic, prior to 2020, who had severe or recurrent episodes of thrombosis and or thrombocytopenia independent of heparin or vaccination. And he found that 8 of the 9 of them had VITT antibodies. So they were positive with this new rapid anti-platelet factor 4 assay. the modified one, and negative with this rapid antiplatelet factor 4 heparin assay, except for one case, 1 of 9 had HIT. So 8 of the 9 were VITT-like syndromes, 1 of the 9 was a HIT-like syndrome. All 9 had had no proximate heparin or vaccine. 2 of them had had adenoviral infection reported. So we now have VITT and VITT-like disorders. Classic VITT was a new syndrome defined in 2021. Spontaneous VITT, or VITT driven by an infection, adenovirus, or in Will's case, CMV, is a new syndrome defined in 2023-2024. And this adds to our increasing repertoire of platelet factor 4 immunothrombotic disorders. We have the HIT and HIT-like syndromes, and we have VITT, classic VITT, and VITT-like syndrome, spontaneous VITT. Just very quickly before I finish, just to say about the prognostic factors, because at the moment, we don't know whether the spontaneous VITTs are going to have a worse or a better prognosis than the vaccine, adenoviral vectored vaccine triggered VITTs, the classic VITTs. We don't know whether the prognosis is going to be better or worse. So let's remind ourselves of the prognostic factors for the classic VITT. So for CVT, the odds of death was 2.7-fold. For a low platelet count, for every 50% reduction in the presenting platelet count, the odds of death increased by 1.7-fold. For every 10,000 units higher of D-dimers, the risk increased by 1.2-fold. Reduced fibrinogen, again, increased fatality. And I'd just like to say, although the original notion was that VITT was a disease of females, we did not find this. There was no change in incidence between male and females. The original notion probably came from the demographics of the people who were vaccinated, which were largely healthcare workers. But if you look at the prognostic indicators for females, you can see that the incidence slightly higher, not significantly different. CVT with ChAdOTS, it was 60% were female, 75% with the Janssen vaccine. Those with severe thrombocytopenia, 65% were female. With intracranial hemorrhage, over 70% were female with both vaccines, and the death rate was over 60% of them were female in death. Now, I've done the statistical significance for both vaccine, and it's not statistically significant, but you can't deny that there is a trend there. And if we had a higher powered study, we might find significance. So in summary, be aware. I totally agree with Will that if there is thrombocytopenia, thrombosis, and high D-dimers of more than 4,000, do the HIT rapid assay. If it's negative, check the ELISA. In future, we are going to have a VITT rapid assay, which is looking specifically for antiplatelet factor 4 antibodies, and we can run these cases through the VITT and the HIT rapid assays. And thank you so much for your attention. Here's our EA expert hematology panel. And as Beverley said, the missing one today is Professor Mike Macris.
Thank you so much, Sue. It was wonderful, so clear. There's one question in the chat that I think is quite pertinent, and then I'd like to leave enough time for Marie. So it's from Sam Ackroyd. He says, should we test D-dimer or VITT antibody in presumed ITP post-infection stroke vaccine in setting of no thrombosis as part of workup?
Okay, I think that's a really excellent question. And I would say yes to D-dimers if it does not look like a straightforward ITP. then yes to D-dimers, and only if the D-dimers are high, then to check the ELISA for the VITT antibody.
Perfect, thank you. So we'll come back to you hopefully at the end for more questions, which there are in the chat. You might want to answer them yourself in a written format. Let's move on. We've got Professor Marie Scully, who is well known to everybody, a hematologist at UCLH and Professor of Thrombosis and Hemostasis there. She's so well known for her work in TTP, but absolutely played a vital part in the VITT story. And I'm going to hand over to her to talk about treatment of VITT. Over to you, Marie.
Thank you very much, Beverley, and happy World Thrombosis Day. Just going to load my slides.
National Thrombosis Week.
That's what I meant. Okay. My task today is to discuss the treatment of these anti-PF4 antibody disorders, of which there is a growing understanding of the terminology and also where we place such conditions. And it is particularly relevant following Will's very sad case. I make no apologies to go back to classical HIT. And that is cases in hospital where we see a thrombocytopenia usually associated with unfractionated heparin. And these are heparin-dependent antibodies. And we see a response to stopping the heparin within 3 to 4 days. So the platelet count starts to normalize. And furthermore, the thrombosis rate seems to decrease after stopping the heparin and is not as high as in other PF4 conditions. I'm going to show this slide a few times and it looks very busy, but there are 3 pertinent parts to it. This one in the red box is really what I'm alluding to with regards to classical HIT, and that is stopping the heparin platelet count normalization. So we know there's antibody production, but really you can hit the spot by just stopping unfractionated heparin or low molecular weight heparin. And then we have VITT, which Sue has obviously just explained in detail, but many people know already about it. This is the extreme. So for this condition, although we can use heparin at the time, we did not know that, but there are alternative anticoagulation options. And I think given the current availability of tests, we should probably consider alternative anticoagulation. But patients also were given high-dose intravenous immunoglobulin, but the very severe ones, and certainly at the end of the VITT story, they were going straight for plasma exchange and using other immunosuppressives. And that's because of severe thrombocytopenia, multiple sites of thrombosis, which was evident in about 20 to 30% of patients, in particular central venous sinus thrombosis. And this was usually multiple sites and so severe that it often was related to intracranial hemorrhage. And unfortunately, that's where we saw many patients die. So on our picture, I've gone to the end of the picture where we see extreme antibodies form. So we know in VITT the antibodies are excessive, but they're also very, very potent. And we saw that in the patients. So for these cases, we need to go in quickly and we need to give therapy which will decrease antibodies as quickly as possible. And that's because the mortality rate in VITT is comparable to nothing else that we have seen for a very, very long time. So it was over 80% without treatment, but even with treatment, about 20 to 25% of patients died. So we had to hit hard with therapy as soon as possible. Now we've got this other scenario, which is autoimmune HIT. And this encompasses an awful lot of conditions. So it's not classical HIT, but it may be patients where there is a temporal association with heparin. So the heparin may have stopped, but they still had ongoing or worsening thrombocytopenia. It may have been patients whom in the past we thought had HIT in relation to fondaparinux, or it may be patients who have recently had surgery or an infection. So it's a real bag of conditions. These are the difficult ones because we may identify both heparin dependent and heparin independent anti-PF4 antibodies. So an alternative anticoagulant is suggested. You can use high dose IVIG and they may well need it, particularly if the heparin has already stopped, but they continue to be thrombocytopenic and continue to develop more thromboses. And there are cases in this group of autoimmune HIT where they require plasma exchange. So I'm putting this group in the middle. So IVIG is probably the mainstay of therapy for many of these patients, but in severe cases, they may need to proceed to more intensive invasive therapies, such as plasma exchange or immunosuppression. We then have this situation of spontaneous HIT or VITT-like disorder. So spontaneous HIT has been around for many, many years. And these are the cases in particular that were related to knee surgery. Why knee surgery? That's a question for another day, but there was various forms of surgery to the knee that resulted in a HIT type scenario. So in hindsight, it isn't HIT because the patients did not have heparin, but it has a HIT type clinical phenotype. There were also cases of, in brackets, spontaneous HIT related to infection, and there were also a third group where there was no obvious precipitant. And now we have the situation, as Professor Greiniger and Will Kenton, but also Professor Will Lester have described, this VITT-like disorder. And actually, when we consider it, these are probably all one of the same conditions. So the thrombosis rate is very high. You can use heparin, but actually, until we have the right analyses available to us, it's probably best to use an alternative anticoagulation. We can give high dose IVIG, sorry about my misspelling of high, but actually plasma exchange is more effective, as are immunosuppressants. And I say that because of the rapid progression and deterioration associated with increasing thrombosis, as we've seen in the case that was presented earlier this morning. So these spontaneous HITs and VITT-like disorder, they are mainly the group that we would consider plasma exchange and immunosuppressant therapy. IVIG, if we can get it and get it into patients, but really they need more. Now, you've already had these two cases presented very nicely by Sue, but they tell us such an important story. So case 1 and case 2 were both the result of adenoviremia. I think this is just by chance. I don't think it necessarily means that all VITT-like disorder cases are going to be due to adenovirus, but I think there is going to be a viral preponderance. But there's also cases of bacterial related VITT-like disorder. They're going to be rare, but they're going to be acute and they're going to have a very high mortality. And the difference between these two cases really is the use of plasma exchange, rituximab and steroids. So it is like a TTP presentation, and that's how we need to consider it. We can try IVIG, we can give it while waiting to transfer, but we need to be mindful of the underlying symptomatology. So when you have CVST, when you have multiple strokes, we have to be cautious of the high protein load when we use high dose IVIG. There are multiple additional supportive measures. We must avoid platelet transfusions. These do make VITT, HIT, and VITT-like disorder worse. Thrombectomy we can undertake, but as we identified during VITT, thrombectomy, and in these last two cases, is almost associated with regrowth of the thrombosis. Neurosurgical decompression from multiple areas of central venous thrombosis or arterial infarction, which is usually quite big, and then we get a secondary bleed or significant intracranial hypertension. We need to be very mindful of the blood pressure controlled, renal function, and add additional immunosuppressants. Now, what they are at this current time is not known, but high-dose steroids, rituximab, were used during VITT, and they were successful at the latter part of the cohort that we looked after. There is an argument to use FcR receptor inhibitors, but they didn't really get going during the VITT episode for a number of different reasons. What we also need to be mindful of for these VITT-like disorder or spontaneous HIT situations is the long-term follow-up. So we know from Andreas Greineker's group that the risk of relapse with VITT is not high. In fact, it looks to be low. But we do know of cases of spontaneous HIT, in inverted commas, that have recurred a number of years later. And that may well be the case for these VITT-like disorders. We just do not have that information. So from Will's case, it fits the diagnosis for a VITT-like disorder. It's extremely rare, it's extremely acute, and associated with significant mortality and morbidity. Heparin-based therapy is fine to use, and having the standard AccuStar or chemiluminescence assay, which is PF4 heparin, can give us some confidence there. Correction of the coagulopathy, which is primarily the fibrinogen, IVIG, and plasma exchange. Thank you very much for your attention.
Wow, that was very clear and spectacularly good, as we would expect from you, Marie and Sue. Sue, would you like to come back so that we can have some form of discussion? There's some glowing reports of the qualities of your talk in the chat, rightly so, because you were doing state-of-the-art presentations. So where do you think we're going with treatment, Marie? Do you think that we are going to find one immunosuppressant is particularly useful? How long should you continue the plasma exchange for? Are you monitoring it as you go?
If it's comparable to VITT, plasma exchange was extremely effective. We know when we did the follow-up that the antibody levels dropped better in those that were plasma exchange versus those that weren't, and it did increase the platelet counts almost quicker. But don't forget, we had patients with multi-site, extremely sick, so they were getting multi-therapies at the same time. So they were getting plasma exchange with IVIG, with steroids. But I think at the latter part of the VITT episode, I think going for plasma exchange and steroids, and in some cases rituximab, felt very, very effective. And I think that's how we treat it until we know more. So inhibiting the FcR receptor is fine, but it almost feels not enough in the acute setting, which is different from the autoimmune hits, which I don't want to use the word indolent because that wouldn't be fair to it, but patients were almost still in hospital and you had time to consider what you're doing and we saw very effective outcomes with IVIG. So I think we need to start compartmentalizing the acuteness and the therapies for these conditions.
Okay, Sue, where do you think we should be going with diagnosis? Should every hospital have these new assays that are coming through?
Well, I would love every hospital to have an AccuStar anyway, because it's really hard with TTP. You know, you've got to really get on all these thrombotic, thrombocytopenic conditions. You've really got to act very, very fast. You know, the chance of survival, if you've missed sort of 4 hours, you've got to act within that time. So in terms of everybody having a rapid assay, I think as long as samples can get very quickly to the centre of expertise, and I know we can do that pretty quickly in the Oxford region, but it's not always possible. And I think we do need to give attention to being able to make that call very, very quickly. So ELISAs can take a bit longer, I think.
Yeah, but we are going to have hospitals where they have a patient with a suspected spontaneous VITT or HITs, and they may not have the assays. So should we be treating them with IVIG? We have the problem, we have IVIG committees. I'm not clear that they would offer IVIG upfront, but it would be quite a big discussion with the committees. Have you got any comments on how we can move this forward politically?
Well, in terms of, I don't think you necessarily have to wait for the results. So we had this very case actually in the Oxford region on Friday, of course, 4 o'clock on a bank holiday on a Friday. And in fact, the diagnosis turned out to be HIT, which was processed on the Saturday. But by Friday, you know, the intravenous immunoglobulin had been given within an hour. The patient was on argatroban, and there was a cerebral venous sinus thrombosis. And, you know, the patient is alive and well. So you don't necessarily need to wait for the results. The index of suspicion is there. And the 40 probability score is obviously very helpful for HIT. And the clinical case criteria for VITT. In terms of politically, as you know, NHS England, although there's a short supply of IVIG, they were absolutely fantastic during VITT. They kept us up to date every single day on the supplies of IVIG. They wrote to every pharmacy in the UK and said, if you are asked to draw up IVIG, but for a suspected VITT, you drop everything else and you just do it. And next year, NHSBT we're going to start our own plasma fractionation, and hopefully the supplies of IVIG will increase and be more local, and we won't have this shortage again.
Okay, so this whole hour has been about spontaneous VITT and recognizing it. And I feel like over the last 20 years, I have probably treated cases because I thought they were catastrophic antiphospholipid syndrome, and we get referred patients with multiple thrombosis. So we should be testing this type of patient, as Will said. I think his words were that the BSH expert hematology panel on VITT would recommend testing for antiplatelet factor 4 in patients with thrombocytopenia, thrombosis, and a D-dimer greater than 4,000. And the question is, how do we get this out there a little bit more? We have 373 people on this call. Thank you so much to everyone who's come. I think you have both educated them enormously. But shouldn't we be having a guideline about managing this type of condition, or guidance? Because we can't do a guideline, we haven't got randomized controlled trials, so guidance. Marie, Sue, what do you think? Where do we go?
Well,
I think we need to have guidance out there for sure. The problem is the paucity of cases currently, and also as I said, recategorizing all these previous cases diagnosed as HIT or other. And so until we have more cases, I don't think we can do a guideline, but we certainly should be doing guidance, because it's going to just affect young people, which is what we've seen with VITT and what we've seen in the literature, and we need to be ready.
So we need living guidance is what we're talking about here. Are we going to reconvene the expert hematology panel?
Why not?
Well,
Yeah, you laugh, but is that where we're heading?
And you and I, Beverley, have already asked twice for the NICE guidelines on VITT to stay, because we recognised a year ago that there were cases that were not necessarily following a vaccine, and we asked the NICE to keep it up. I think with a few more cases that have been presented now, both from Professor Wilkinson, Greinacher and Lester, then, you know, we can perhaps persuade them a little bit more on that. In the meantime, it's easy for us to have a working guidance on the BSH website with the disclaimers that we just simply don't have enough information at the moment. We don't know the prognostic factors, but at least people can start doing the clinical and laboratory diagnostic tests.
Okay, so I look forward to further development, Sue, as president of the BSH. I'm looking forward to you organising that. And I think that Thrombosis UK would like to write to NICE yet again to say, why have you parked your VITT guidance, and could we update them? So just moving on, there's a few questions. Someone's saying the name. Should it be spontaneous VITT? Should it change? Should it be infection provoked? Something. What are your thoughts, Sue? What are your thoughts, Marie?
Well, I think the nomenclature is in a real pickle, because because everyone's understanding more and more with the new assay. So firstly, I'm not sure that we should be the ones changing it. Will Kenton is the god of this, and, you know, publishes prolifically and is very good with it all. I don't think we should have spontaneous HIT. I don't think we should have spontaneous VITT, but I also don't think we should lose VITT. I think we need to remember where it came from. But I don't know what the answer is. I think that Will's very good at defining acronyms for conditions, so maybe we'll leave that one to him.
Sue, what do you think?
Well, I like the umbrella term of platelet factor for immunothrombotic disorders or immunothrombotic syndromes, PFITs, because until you can investigate your case, whether they're VITT-like antibodies or HIT-like antibodies, you won't know. And so there needs to be a kind of generic management pathway for unspecified PFITs, if you like. Ted Walkington and Andreas Greinacher at the moment do use VITT-like syndromes, HIT-like syndromes. So I think it's reasonable to stick with those at the moment. I think it's quite difficult to, the autoimmune HIT is quite difficult, because what we're looking at with autoimmune HIT is when the antibodies don't become non-heparin dependent anymore. And so that could still be triggered by HIT, like persistent HIT, refractory HIT, as Marie has described. So the autoimmune and spontaneous is difficult. It's difficult to tell the difference between a spontaneous VITT and spontaneous HIT or autoimmune HIT if there's no proximate heparin and we are not testing. And if we're not testing, we don't have the test. But hopefully Andreas Greinacher's test, his chemiluminescence modified assay rapid test, will be out soon, and we're at least kind of home and dry on that front.
Good, good. And maybe the ISTH will have some committee that will decide the final names as they did with the DOACs very early on. Okay, I think I'm going to wrap it up here. That was an extraordinarily wonderful session. Thank you for your spectacular world-class talks. I have to say thank you again to Will. We're coming out of this meeting with action points. So we're thinking about, do we need to be doing living guidance? And the second one is to write back to NICE to get them to reactivate our old VITT guidance and update them.